Okay, I'm going to talk today about clinical decision support, past, present, and future, and try to kind of make this a little bit stimulating as opposed to the usual CDS type talk. I'm also handicapped a little bit by an article that came out just yesterday. So clinical decision support systems are software that directly aids clinical decision support, making decisions about individual patients. I'm very focused, and it's very important to get definitions straight, because technically clinical decision support is me going up to you and asking you for advice. So it has to be computerized, and ideally it has to be specifically about the patient in the right context. Clinical decision support past is prologue. We all know the famous expression that begins with past is prologue. A lot of the systems that were first built proving that clinical decision support was invaluable were internally developed and validated. They were not commercial systems. They had extremely advanced architectures with knowledge bases. They incorporated patient data. They had rules engine. They had medical knowledge bases, and they were very good at being patient-specific, and they even had clinical event monitors. I can tell you, for example, our vendor, and I know others, struggle to actually have a clinical event monitor. So you actually have to open the chart to trigger the clinical support. It's not happening in the background. Now the past. These are great institutions. They still are in informatics. Beth Israel Deaconess pioneered many of the concepts we see today in outpatient electronic medical records. Reagan Streif and MGH also did the same. Intermountain, Brigham and Women's, and I would add Vanderbilt, are known for their pioneering work in inpatient systems. This is where we come from. This is an example, and I can display it because they've publicly put it out there, from partners of their clinical decision support system. You can see the advanced complex architecture and how it was designed to be part of the system, not just another module. Now, we also know from the past that there are two types of clinical decision support that a system can provide. One is push, one is pull. Sounds very easy, very simplistic. It's not. Pull means you go up to the computer, you're doing something, you're looking at a patient, and it's saying, by the way, doctor, nurse, PA, NP, whatever, that you need to do something. Push means you're sending alerts to people who are not expecting it. You're sending it wirelessly. You're sending it to devices. It's actually much more challenging because you have to get the provider right. We know we can change behavior through pull clinical decision support, through things such as reminders, alerts, guidelines. But the question I would leave you with on the past is, did they really change anything? I mean, they demonstrated results, but did they have a lasting impact? Are they replicatable in commercial systems? A hint of problems to come is the success of a reminder is often proportional to the difficulty of the task that the user is being reminded to do. So if you look at the literature, including the article that just came out yesterday from AHRQ and Annals of Internal Medicine about CDSS, health maintenance, preventative health care is always at the top of the list because it's easy to do. It's easy to get people to be reminded to do a flu shot. It is very hard to get people to be reminded to do a pap smear if they're not a gynecologist, because it's a multi-step process. Fill out, generate a form, do a referral, get them to a gynecologist, have the gynecologist, do the exam. While influenza vaccination, I'm essentially pressing a button. I put it in, nurse does it. And again, I'm an internist, by practice. So, what did they change? The old systems looked at inpatient adverse drug events. What's fascinating, if you review a lot of the literature on the impact of inpatient systems, HIT, on healthcare, it's mostly on inpatient adverse drug events. It's not on that wide a variety of topics. There's also some great work out of Intermountain from Scott Evans on antibiotic prophylaxis for surgery. Corollary orders, which means you put one order and another order launches, meaning if I'm ordering gentamicin, I know that I need a gentamicin level. Health maintenance, which is also preventive health. Nephrotoxic drugs, which is more outpatient, we see this, and alerts on Coumadin, heparin, more outpatient. But half the list is at least inpatient, the first three items. The modern era is extremely challenging. We have commercial systems. The architecture is sometimes simpler, and it's less enabled. Yet we have consultants and companies pointing to the previous literature going, look at all the wonderful things we can do. My favorite story is when a consultant during a CPOE selection process handed me an informatics article and stamped proprietary on it. Objectives are many. Organizations are faced with multiple pressures, cost cutting, revenue increase, competition, and this is driving it where in the past clinical decision support was basically what do we need to do, what do we think will help the patient, what's an interesting research question. We now have goals driven by external pressures. Meaningful use is basically telling us what clinical decision support based on what quality and other measures they want to see happen. And we are having a serious challenge replicating the results from earlier studies. There have been some, particularly in the ambulatory arena, where most of the CDSS has been shown to be effective. They have not found this. And there's studies by Islami, Jaspers, Romano, Stafford, Welch, all raising questions about the ability to impact care quality and change outcomes. Remember, the early work showed they could change something. It did not show there was a change in outcome and quality. Many factors can affect how well CDSS performs. And there are several articles. One of them is how good is the clinical data? Telling me that every patient I see may have a high potassium, and I'm an end-stage renal doc, is not useful clinical decision support. It's not great data. Physicians have stated over and over and over, we want efficient, useful systems with a good interface and workflow, yet we don't see a lot of that. Usefulness and relevance have also been identified by Bates and Rousseau. Helpfulness as well as relevance have been identified by Bates, Cooperman, and others. The conflicting results in the literature may reflect differences in the systems they're looking at, the workflow, the usability, and the content. How many of you, just by show of hands, would want to, I hope one of the authors is not in the audience, but how many of you, by show of hands, would want to do clinical decision support in outpatient for chest pain? Is there anyone? Well, a study came out saying it doesn't work, and, I'm a little bit pragmatic and was like, duh, but there's stuff that's so non-specific and hard to track and needing so many pieces of data, you have to take a step back and ask. On the other hand, telling someone to get a flu shot, that works. It's specific, it can be narrowed down, and it's simple. Poor user interface design and redundant entry of data have led to poor use of these systems. It really indicates the need, and Ross Capel, who's in the audience, autographs will be later, that we have to assess usability. We just can't keep going about this of there's a great smartphone commercial for the new Windows phone going that the United States has been doing beta testing for smartphones with all the defective phones. That's what we're doing with throwing some of these things out here. Feldstein and others have found that being delayed by the alert, Sittig, who's to my left, is having time to respond to the alert is a factor. Difficulty interpreting the alert or receiving the same alert were common frustrations. The need to get user feedback was noted in multiple studies. We've actually just about completed a study, in about a month, that we use usability to design our CDS. There's a clear need for usability. Now, some of you may be saying medication decision support, is that part of CDSS? Is it a subtype? I actually think it needs to be broken out. I actually will debate with anyone who tells me drug allergy alerts are the same as an alert for the potassium is too high or that the patient may have sepsis. They're not the same category, they're not the same function or same point in the workflow. This was identified as a category around 2004 in the early days of e-prescribing. The difference is medication decision support is appearing at the moment of ordering the medication. and it may use different mechanisms in the EHR: drug, drug allergy, drug disease, drug lab, cost, dose checking, as well as default dosing. Now, drug, for those of you old enough to remember, is like missile command. It's like you're getting so many things incoming, you're trying to figure out which ones to shoot, for those who played the video game. Drug disease and drug dosing, if you review the literature, are the only ones that have ever been shown to be effective. Now, they have, MDS, as I said, has different characteristics and behavior. It's integrated with ordering. It's not called up elsewhere in the workflow. It's especially true with e-prescribing. And lessons on MDS don't translate to CDSS. I would not take drug allergy fatigue and start saying that's my literature on CDSS fatigue. Now, my concluding thoughts on commercial systems, looking to the future a little bit, is water everywhere, not a drop to drink. Every one of them has one. Every one of them promises it'll transform you. If this was 10 years ago, save you millions in patient safety, maybe billions. But these systems are not at the functionality they should be. One of the key things that you can do with a commercial system, we've done and other places do, and we may or may not get to present this at AMIA this fall, is an ordered and thoughtful process. You have to really screen what's coming in, not, hey, I got an idea for an alert, let's go build one. And you can base this on things like David Bates' 10 Commandments, which say things like it should be at the point of care, it shouldn't divert someone to a different workflow, it should give all the data that's needed. That information's there. It's unacceptable to design without these principles. You have to carefully analyze your triggers and workflow. What is going to be the trigger? What point in the workflow? Not just we need to do this and it won't work, but we're going to put it here. Ideally, you should do usability testing. It doesn't have to be a publication each time. It can be quick, dirty, and inexpensive. And we know we have fatigue issues with alerts. Questions I'd ask: is process really king in these systems because of their limitations? Who needs to be trained? Our study just completed, we think we showed training actually made a difference. You may say, okay, they're trained on the EHR. I don't understand why I got to train them on this. Because they're not really using it. They don't understand it. They don't understand why it's important. What can we do to ensure workflow integration? When do we push back on external drivers like meaningful use and say, this is nuts, it can't be done? I don't really care that you keep, saying this. Obviously, we don't want to get into trouble, but I think saying there silently and saying we'll figure out how to do it somehow is not an answer either. External or internal decision support. There's a big push for external decision support now that the EHR sends data out to a system. System sends something back, and then the EHR offers decision support. This is to help standardize and free up in terms of function, flexibility, but it's to help standardize what some of the rules are. The problem is most of the systems and most of the protocols today we have in IT don't really support good integration with the EHR, and what will happen is it will say you need to order the following, FYI, and then you're going to have to go look for the order. We actually think in a project of ours we may have found a way around that, but my point is external is not a panacea. Any of you guys use either Radport or any radiology decision support? You know what I mean about what external decision support looks like in an EHR. So, for example, Radport, and I'm not picking on them, basically will give you, after filling out information, will give you an assessment of whether you should order the test. If you decide to order another test, you've got to fill out the assessment again, fill out the diagnoses in your EHR, fill out the orders with the explanation, it's not our fault, it's the vendor. It's a much deeper issue than that. How do we systematically test usability? Most operational production shops don't understand what usability is other than getting the users to sign off they like the system. I want to talk about an example of how this all plays together. It's a recent example from my experience. One is what we call the potassium alert. So you get a pressure in a driver where someone very highly placed says, I think we should alert on all high potassiums. It's We have a very thorough CDS process, and we were able to go through it and kind of dismiss it for reasons such as our EHR doesn't have system functionality to look at delta, what the past potassiums were, doesn't have a great ability to look in context. The potassium's always been running 6, doesn't have really push alerting because physicians are not sitting glued to the computer waiting to see a potassium alert. And that gets to workflow support. Where in the workflow are you going to tell someone to do this? It's an example of the thought process you've got to go through. Now, the future of CDSS is going to be on clinical trial recruitment. There are multiple studies demonstrating the effectiveness of this. Genomics, and some of the work we're actually doing work on both of these. And genomics and integrating genomic decision support, because if the genomic revolution starts producing external results that don't integrate into EHRs, we're going backwards again with external links and information that doesn't tie into the point of care. And genomics affects every specialty. We've had to explain to our vendor multiple times, this is not genetics, this is not germline tests, this is stuff that someone will come in with heart disease, someone will be on Plavix, they're not going to go to a genetic counselor for that. Changing behavior through CDSS. We looked at that in our study, can you really change what people do? We did a study called ICPR, Integrated Clinical Prediction Rule. We're writing up the big article on it, there are 2 articles in Medline already on it. And what we did is we proved that a new form of clinical decision support, clinical prediction rules, which are rules based on paper like for sore throat, the Ottawa ankle rule, back pain, etc., could be integrated into an EHR using off-the-shelf functionality, and that training and usability made a significant difference. This is what I think the future is in terms of research. Again, integration and data flow, not how many separate systems can I build. So our plan, and we're actually doing this, is we have a biobank which stores the genomic results. There's going to be some processing by another system that's going to send to our EMR, that's going to tell the physician something, and we're going to try to figure out how to integrate our personal health record at some point in the future. That's all I have to say. I'm hoping I provoke some questions and some thoughts. And
we ask you to hold your questions to the end of the session, and we'll do the big Q&A then. All right.